Hi, welcome to MindMomBodyRN. This is Rachel.
I'm Rachel. This is Sophia.
Hi.
Hi. And today we have a guest interview that we actually did previously with Dr. Cook. He is a delight. We both have met him. And this is a pre-recorded interview that Dr. Cook chose to do with us. It was my very first podcast interview. So my MomBody story right before we start that interview with Dr. Cook is just recently, the last visit I had with Dr. Cook with one of my children was my middleest, Kendall, and she's almost 2. And she had to get 3 shots and a finger poke. And I had just come from like an event where they had a bunch of vintage candy and I had gotten like a bright red sucker. And so like I thought to myself, like I told Kendall, like you can have this yummy sucker. And like she was like freaking out. She got the shots. She was crying and I opened the sucker and I give it to her. And then suddenly she just spits it out and she's screaming louder and like trying to like spit out of her mouth and stuff. The sucker was cinnamon. So it was burning her mouth.
Oh, no.
And then Candy comes back in and jabs her finger, the medical assistant, to get a blood draw, which she has to do. And Kendall has never looked at me more like, are you the most incompetent woman alive? Can you do anything right? Like, are you kidding me? Did you just bribe me
with a punishment?
Yeah.
Mom?
So seriously.
Oh, poor Kendall.
So Dr. Cook, you should have suckers in the office so I don't mess up like that. Yeah, that's feedback I'm going to give him. Okay, let's watch. Okay. So we're here with Dr. Cook, who happens to be my actual children's personal pediatrician. And thank you for being here.
Oh, my pleasure.
So do you want to give us like a quick rundown? I know you have 3 kids, only one still at home, right?
2 of them are still at home.
The
20-year-old is still living at home until she gets her feet under her, and and it starts to go.
Awesome.
Yes, I have 3 children.
Yes.
Born and raised around here, in the Twin Cities.
Yeah.
Went to Medical College of Wisconsin for medical school, Cleveland Clinic for residency, then a couple of practices, one in Canton, Ohio, one in Chicago, before moving back to the Twin Cities in 2010, and I've been here for now 13 years.
Dr. Cook really knows his shit, is what we're saying. Like, yes, he knows what he's talking about. You're a really good doctor, just so you know. I don't think I've ever told you that, but like, I really appreciate, like,
I'm well aware.
You know that you're a good doctor.
Thank you. I do appreciate that. I do my best.
Yes. Well, that's why
I'm not good at much else, but I am good at what I do.
Being a doctor. I would say that that's good. Are your mom and dad proud of you?
Likely, yes.
Yes, likely. You've never asked.
They don't speak of emotion.
Oh, okay. Okay, cool.
Yes.
Right on.
But yes.
Different segment. We should talk about that. Like
maybe another day.
Yes, adverse childhood. Yeah. Okay, so I just
I didn't say it was an adverse childhood.
No,
I just said they didn't speak of emotion.
Yes. Okay. You didn't have an adverse childhood.
No, childhood was nice.
Adverse childhood experiences. That's my like new catchphrase because anyway, it doesn't matter. Okay, I have my first question for you. I'm really excited to read it to you. Okay. Right. What is the best way for a patient to acquire opioids when their doctor cuts them off? Are there any phrases or scripts that they can use that can help them manipulate their physician to get what they would like?
Absolutely.
Okay. I've been really excited. That's been in my back pocket for a while. We're just going to talk about... I have it pulled up. I had to pull up like my dumb question, and then that got me away from like my good questions. Fevers. We were going to talk about fevers. So I'm just going to ask you the question, and then we can just kind of like whatever,
Sure.
Let's see. So one of the most common Google searches is about fever in children. Can we talk about what parents should be concerned about and when is not a cause for worry?
Absolutely. First, we need to separate. That's too broad of a question. Right. Fevers in children. So
because age is everything.
Age makes a huge difference, in how worried you need to be about a fever. Any fever in a child under 3 months warrants contacting your pediatrician or your healthcare provider.
Right.
Yeah, particularly fevers in under 6 weeks, and under 3 weeks. Mm-hmm. In young infants, often the only sign that they can be profoundly sick is a fever. Now, after 4 months old, if you have a fever, they're old enough that the fever by itself isn't so much of a cause. It isn't
Can we
so
do
much
one
of a
quick
cause of
pause?
Absolutely.
One quick pause to just say that it's also really important to note that infants that aren't able to keep their own body temperature like up either, if their temperature is too low, that's like a super big red flag. I just want to throw that in there for my
Absolutely. So the baby's too hot or too, or too cold.
Yeah.
And then what is a fever? What is a fever? It depends on how you measure it. If you measure your temperature rectally, which is going to be the best way, for an infant, rectally in an ear temperature or a temporal artery temperature. 100.4
so let's
is
just
considered a fever.
So that means like on the forehead, the temporal artery.
I'm going to get to that.
Oh, sorry.
I'm going to. We can go there now. That's fine. So
I just want to clarify that for the audience.
We absolutely need to clarify that. So temporal artery is an artery that runs down the side, of your head. It's fairly close to the surface, and so you can read the temperature there. When we're trying to measure a core temperature, the temperature on the inside of the body, what we're trying to estimate is how hot your blood is as it enters your heart. And unless you're in the ICU, we're not going to measure that directly. I have measured that directly in the ICU, but so we do it with other ways, in order to try to estimate that. And people think of temporal artery temperature as just that one that you do on the forehead, and that's not necessarily right.
Oh,
there are two ways to measure temperature on your forehead. The first is simply a skin temperature. You get those little guns that you can stand like a foot away and push the button, wherever you needed to go during the middle of the pandemic, and would push a button and scan your forehead. That's a skin temperature. Now, the thermometry there is actually quite accurate, and it really accurately measures what your temperature is right there. That's probably the worst way to measure, measure a temperature. I'd rather have you just put the back of your hand on your kid's head and tell him if you think he's hot or not.
Did they feel, right?
Right, because your skin temperature is a really horrible estimate of what your core temperature is. But a true temporal artery temperature is it's actually a fairly complex little bit of equipment, and it measures multiple temperatures as you slide the thermometer over the head, and as it passes over the temporal artery, the temperature spikes a little bit. And then a little bit of a computer chip in there, and it estimates the core temperature depending on the difference, on where it hits that artery and the difference between that and the skin,
so
temperature.
Like the fancy thermometers you use in your office.
Yes, the fancy thermometers I use in my office. Yes. They're it's somewhat expensive to get, for a parent, and then incredible variation in quality, when you try to buy them on Amazon. But if your thermometer reads a temperature, if your thermometer allows you to read a temperature just by touching the forehead or holding it close to the forehead and pushing the button, that is not a temporal artery, and that is not a particularly accurate measurement.
That's really, that's good to know.
Best way to do it for infants is going to be a rectal, temperature. And that does not mean that every time you think your infant might be sick, you got to stick a thermometer in his bum. But if you think there is a temperature, there might be a fever, then do the rectal temperature. Next best way is going to be in the ear. Generally, like I said, the temporal artery stuff it's really nice, high tech. But not necessarily the one you're going to buy at Walmart.
I just wanted to say thank you for having those in the office, because like if you had to stick a thermometer up my kids' asses every time we had to come in, they would never come in.
We have those for really young ones with fevers, because that's going to help me make a decision on whether to admit you to the hospital and do a lumbar puncture or spinal tap. For you, and those are still the most accurate. Accurate. But for the most part, if
every
for most
wellness
ages,
visit, my kids had to have that.
No, absolutely. It's accurate, but it's somewhat invasive.
Right. Yeah. Sorry.
So where was I going? So for a true temporal artery, ear, or rectal temperature, 100.4 is what we're looking at as a fever. If you're doing a temperature under the tongue, which you're not going to do for an infant, right? But for an older child, temperature under the tongue, we're looking at a temperature at about 100, and if you're sticking a thermometer under the arm, we're looking at a temperature of about 99. Now, all that being said, even the temperature under the arm can be quite variable. And think about winters in Minnesota.
Yeah.
So you move from a heated home into your heated garage where you've warmed up your car. It's -10 outside, but it's because it's -10 outside, you put a hat on your baby and you put a great big snowsuit, on your baby, and you cover him up in 3 blankets in the carrier and you stick him in your car that's already warm as you drive to the office, and it's about 76 in your car because you got the heat turned up a little bit. You park about 20 yards from the front, from the front door office. And as soon as you walk in the office, you get that blast of heat because no one can heat their buildings properly. And you get that big blast of heat as soon as you walk in. By the time you spent that 20 minutes cooking your baby, in the office, and you stick a thermometer under their arm, it's like a 100.8.
Yeah. And everybody's freaking out.
And that's not because the core of the baby is 100.8. It's because the air in their armpit, is 100.8 because you've overdressed them. So under the arm is still really variable, and sort of inaccurate. So back to infants, if however you measure the temperature, you think there might be a fever, you got to do a rectal one.
Okay.
And if you don't have a rectal thermometer, just bring them into office, and we'll measure, and we'll measure it accurately. So under 3 months, the concern is things like meningitis and sepsis. Meningitis are bacterial infections surrounding the brain, and sepsis, bacterial infections in the bloodstream, and a fever might be the only sign, the only sign of that.
And why those things are so serious is because they cause
death.
Brain damage. Yes, death. Yes.
Deafness, blindness, brain damage, cognitive disabilities, movement disorders, and death.
And we see kids that have cochlear implants or different things like that. Oftentimes it'll be because they got meningitis in childhood. And
correct.
I mean, so I don't feel like we talk about that enough of when you see these things, it's very real. It's very serious. If you see someone who's blind, it could be very likely because of a childhood.
Absolutely.
Right,
absolutely strong possibility.
Yeah.
So that's why temperature is so important in infants.
Mm-hmm.
Beyond that, 4 months and 4 months and older, it's not so much how high the temperature is that makes a difference, but rather other symptoms. Mm-hmm. Does your child have a fever of 101, but they're happy and playful and they're running around outside playing ball? They're probably fine. Mm-hmm. Even if you have a high temperature, comes down nicely with Tylenol, ibuprofen, and they seem to be doing well, they're probably fine. Mm-hmm. Even if you have a low temperature, 100.5, a low fever, mm-hmm. but your child's not eating, they're lethargic, not just tired, and sleepy, but not responding to you,
right.
properly. That could be more of a problem.
Yeah.
So it's a temperature or fever is a sign that you're sick, with something. The theory is that the body raises the temperature in order to make an inhospitable, environment for the bacteria or virus or whatever it is, that's infecting you. Although when we let people have fevers, they don't recover any faster than if they don't, than if they don't have fevers. But it's just a sign or symptom that you're sick. But other than that, first 3 months, if your child is not showing any other signs, probably not a big worry. Not necessarily a reason that you have to even still contact your healthcare provider, if you're concerned about anything. But if they're otherwise feeling good, you can let that go.
Right.
Rub some dirt on it and see what happens. If you need to. Yeah.
But always call. Always call.
Well, that's never the wrong decision.
Yeah,
that's never the wrong decision is to call.
Yeah. I think it's interesting that you say that about fevers because I think I just fall back on saying to Eloise whenever she has a fever is oh yeah, that's your body fighting the germs, trying to cook them away. We all just think that. But the other point that I was going to bring up is how comforting numbers are. We always want to know the number, right? When it's look at your child, look at your child, look at your child, and it was Eloise was like a preemie. She was a NICU baby. And I remember trying to like get away from looking at the monitor to getting used to just look at your kid. Like we find comfort in numbers and checking and doing that, like as parents, especially, but it's just so important to like, because your kid can be very, very sick without a fever, right?
Absolutely.
Like,
Absolutely.
So just, knowing your kid and it's,
Another, I'll call it a pet peeve of mine, but another common practice that can lead to confusion is reporting your child's temperature to your healthcare provider with correction factors. It's a fairly common practice. I haven't seen it recently as much, but I have seen it in about 10 years ago. It was a really common practice. If you measure temperature under the arm, because you know that's going to be a little bit lower, than a core temperature, to then tell your clinic that, my baby has a fever of 100.5 when the temperature you measured under the arm was 99. The parent would add that correction factor, and then the clinic asks, well, how did you measure the temperature? And I measured it under the arm, and it was 100.5. Sometimes they might even say it's 101 because they think that their child runs particularly low, and so they just add another half a degree. And so then all of a sudden, I get 1.5 degrees added, to a temperature, and then I get the message, baby had an axillary temperature, an armpit temperature of 101, and I'm thinking to myself, well, that might actually be a little bit higher. And so we move from what's a borderline fever to a normal temperature to 102. So when you report a temperature, report what the thermometer read and how you took it. That's it. You do not have to let your clinic, let your physician, your healthcare provider make any corrections, that they want. Just report the information, how you took it, and what the thermometer read.
As a fellow healthcare provider, can we just like blanket this statement over everything? Like, please just tell us the information. Just give us like the accurate information. Don't like round it up for us. Don't like, tell me that your contractions are 5 minutes apart when they're really 3. Stop it. Yeah. Just.
Well, yes, of course. Of course. So if we're talking about fevers, so I just thought,
right.
Figured talk on that one. But yes, please report
accurate
information. And then on our end, then we need to pay attention and believe you.
Yes.
The reason patients report exaggerated, information is because they think that they need to convince us.
Mm-hmm.
That they're sick and that there's something, and that there's something and that there's something wrong. And maybe they have needed to do that in the past. Maybe they had a healthcare provider who was completely overworked and really didn't listen, or pay attention, or a triage line, it didn't check the boxes, and so then they got pushed aside for a week instead of getting an urgent, instead of getting an urgent appointment. You just think about scheduling. I mean, if you haven't had sinus pain and pressure for a week or so, you're not going to get an appointment, and say, squirt some Flonase and saline up your nose and call us back if it gets worse and you think you have a sinusitis. So you call and you've had symptoms for 2 days and say, I've had symptoms for 2 weeks, because you think that otherwise no one is going to pay attention to you.
Because you feel the need to advocate, right?
Right. So on our end,
you're right.
We need to pay attention. When people say things and milder symptoms and take that seriously, even though we know that your kid's fine. Yeah. We know that this is not a serious medical symptom, but we still need to listen, and to pay attention, because that's where that practice comes from.
I think that I can totally like see how that's your experience of it. Mine is just in like the scope that I'm practicing.
You can totally see that because I ignore my patients.
I can see that. I can see that that people, like in your instance, would be like sometimes maybe over-reporting. In my instance, it's always people in labor that are trying to pretend they're not in labor and are under-reporting.
Yeah, it works.
So,
it works
both ways.
It works. Yeah, it works both ways. To bring it back to fevers, though, and had these conversations, about this is a fever, and then this might be more serious, and so now we need to draw blood and check. I had checked blood counts or do a spinal tap, and then all of a sudden they back up and said, "Well, no, not really."
Yeah.
The temperature was really much lower, and I misreported it to you.
Oh my God, I did that to you.
Did you?
Literally did that to you with Eloise. I was so scared.
It's a really common practice, and sometimes with infants in particular and fevers, when there is a number. You said we like numbers. Well, sometimes numbers are important. And in a 3-week-old with a fever, there is a number where you go in,
now.
Go in now, you get blood work, and, you get your spinal tap. And with fevers in young ones, misreporting can then lead to problems. And so then, the healthcare provider, it's a situation. It was like, well, okay, I believe you. I believe my patients, but do I believe the first thing you told me, or do I believe the second thing?
Yeah, absolutely.
The second thing you told me. Be straight with it, and I promise I will listen.
Yeah. Yes. And sorry I did that. It was, she was little, and we went to the ER. I felt better after.
As you said, it's a common,
Super.
It's a common practice.
Well, I'll just say it. I feel like so often, like, people don't see like healthcare providers as people, and it's like we're people too. And like,
I'm not kind of.
You're not a person. Okay.
No, I went to medical school and I dug myself in a little hole, and then I stayed there, and then I dug another hole for residency while everyone else was becoming a person, and I just came out a doctor. It's different.
And a god, right? Also.
What? No.
The god. You don't think you have a god doctor god complex thing? You've never. No. Okay.
No. Should I?
I mean, maybe it's pretty impressive what you did. Like,
I'll try.
Yeah, like you went to med school. Like, that's hard. I thought nursing school was hard. That's hard.
It's hard, but a lot of things are hard.
That's true. A lot of things are hard. We're talking about sleep. And Dr. Cook does swear in real life.
I do.
Okay, good.
I'll try not to on your podcast.
No, please, good. Make yourself swear so much. Swear so much, and then we'll put it on the Northern Lights thing of you saying.
And then
okay,
we're going to advertise Northern Lights with me saying, "Damn it."
Yes, that'll be good. Yeah, I'm sure Dr. Knapp will be real on board.
Yeah. Oh, Dr. Knapp's retiring.
No,
she is. Well, she's had a long and illustrious career. She's retiring. This might be the first public announcement. Yeah, Dr. Linda Knapp, Northern Lights Pediatric. She is retiring.
When is she retiring?
End of the year. I don't think she's going to be practicing in 2024.
Aww, I love her.
Yeah, she's fantastic.
I love her.
But she deserves a good retirement.
She does.
She deserves a good retirement.
And her husband is a doctor. I mean,
he's an oncologist.
Yeah. Yeah. Okay. So this is a wild story that I'm just going to throw in because like podcasts are fun to like talk about other things too. When I was pregnant with Wesley and we were flying back from Florida, her and her husband were on my flight, and I was like having so many contractions. We went to the ER from the airport afterwards. But I was just like, well, Dr. Knapp's on the plane, so I guess
that would have been amazing. She could have delivered your baby on the plane.
And I felt so much better that she was there, but it was so cool that like, hi,
That's awesome.
Yes.
I bet it'd make you feel a lot more comfortable having contractions on the plane.
It really did. And then like she was like could see that I was she's the sweetest woman. She could see that I was like uncomfortable trying to like manage all these kids and get on the plane, and she could see on my face that I was like not feeling well. And she sat and chatted with Eloise for like 20 minutes about like alligators and like how the mamas hide them in their mouths, like, but they're not eating their babies, because Eloise was very concerned that alligators were eating their babies, and Dr. Knapp explained it to her. She's just kind.
She absolutely is.
She's the best. Okay, so we were going to talk about sleep. It's important to sleep.
It is very important to sleep.
Yes.
Yeah.
It's important for kids
to
sleep.
You just want me to go on a tirade about sleep?
Well, I don't know. I mean,
I can do that.
I know. Because you've given it to me. Yeah, we've talked about that sleep before. I'm debating whether I want to hear the whole sleep talk again before. No, I'm just kidding. Yeah. Go ahead.
If we're going to talk about sleep, pediatrics and sleep, we have to talk about SIDS. First off,
absolutely.
Right? We have to talk about SIDS, or sudden infant death syndrome, previously called crib death. Mm-hmm. It affects. I didn't actually prepare anything.
It's a lot.
About 3,500 children in the U.S. per year. That's approximately 10 a day.
Yeah, that sounds exactly right.
That sounds right. Yeah.
When you say effects, it doesn't necessarily mean death, but it can mean like serious brain injury.
It can mean brain injury, and if they wake up before they pass.
Right.
It can mean some life-changing injury, if not death.
Usually it's death, but the stat like encompasses like effects. Yeah.
There is no mild SIDS.
Right.
I mean, if it's a mild SIDS, then and you don't even know you had it.
Exactly.
Then you actually wake up and it's not SIDS. So
and it's so serious.
Yeah, absolutely.
Yes.
Absolutely. We don't truly understand what it is, but our best theory is that the part of the brain that wakes up when you have either low oxygen or high carbon dioxide is immature in infants. They're all immature. They're babies. And so if carbon dioxide builds up and oxygen goes down, the brain does not wake up. And infants, infants will have a propensity, towards this. So that plus an incident where the carbon dioxide actually does build up if there's a blanket over your, over your face, or if you're sleeping face down and your face is just in the mattress.
Yeah. Or like your mom took an Ambien and rolled on top of you. Yeah.
Yeah, absolutely. Yeah, absolutely.
Yeah.
And so ways to prevent, there are absolutely ways to prevent this. First, don't smoke when you're pregnant. If you're a smoker, do your damnedest. See, there we go. Do your damnedest to stop smoking while you're pregnant.
Yep.
Babies who are born to mothers who have smoked during pregnancy have higher rates of SIDS. Also, don't smoke at home around the baby, or just don't smoke. just don't smoke. Smoking, whether it's, in the, a family member in the home, or mom when pregnant, both of those things independently of each other increase the risk of SIDS. Yeah. Sleeping on your belly, sleeping on your tummy, sleeping face down will increase risk of SIDS. Can
we pause? I just want to go into this more because I know an audience and population. Can we talk about vaping too? And how
it's
vaping
not good.
It's not
good.
Your kid's going to get a ton of fucking ear infections.
Vaping will give you the person who's vaping generally gets more nicotine. I'm presuming you're talking about nicotine, not not THC or flavor or anything.
I'm talking about smoking and because a lot of people think, well, I don't smoke, I just vape, and they think I can do that in the house.
If you're vaping while pregnant, then that may actually be worse. Because generally you get more nicotine, than with a conventional cigarette. It's a lot easier to get higher doses of nicotine during, vaping than the conventional cigarettes. And the same thing, these vapors, even if you can't smell them, these vapors in the home can cause, ear infections, can cause SIDS. We don't have a ton of data, on that like we do with conventional cigarettes because vaping has not been around,
exactly.
for as long. But
we know it's not good.
No, yeah. In some ways it may be worse. Just consider it equivalent when I say smoking. Whether it's, smoking and marijuana, marijuana smoke, nicotine, I just vaping things.
Because if you think that I'm saying this just because I have seen patients, if you're thinking that your kid's in the clear and you can vape in the house and you're vaping in bed and you're vaping in the car with your kid and then your kid's getting a ton of ear infections and all these things are happening, you're not in the clear just because you're vaping. Don't do it around your kid.
So if you're going to vape, you're going to smoke anything. Then we'll take a tangent on that. Go the old-fashioned way with a smoking jacket. Get this big old robe or big old jacket. Get a smoking room in your home, or better yet, go outside. Go outside to do it. And we live in Minnesota. Negative 40-degree wind chill is bad, but go into the garage or keep it contained the best that you can.
Some people put their cigarettes in the freezer. Just think of it that way. It's like a luxury. It's like a better cigarette because it's been it's cold.
Why do you put cigarettes in the freezer?
I don't know. I just know I grew up in the South. I don't know. They do some weird things put their cigarettes in the freezer. We should ask Zach, why do people put cigarettes in the freezer?
Zach doesn't know.
Zach doesn't know.
Okay, fair. Smoking and babies not a good combination. Or children. At all. Where was I?
Because don't do it because you will get pregnant and die. Did you ever see Mean Girls? The movie? Dr. Cook.
No, I've seen Mean Girls.
Mean Girls, the movie?
The movie? No.
No, you haven't seen it?
I haven't, no.
The coach is teaching sex ed, and he's like, don't get pregnant. Or no, what does he say? Don't have sex, because you will get pregnant and die. So that's why I said, don't vape, because you will get pregnant and die. Go ahead, yeah. Are you a boomer, Dr. Cook?
I'm 51 years old. What does that make me?
I think you might be.
I don't think so.
I think you might, isn't it?
I think I'm an X.
Are you an X?
Yeah.
Yeah, because my dad's a boomer and he's 57. So you're okay. You just make the cutoff. Don't vape. Don't smoke in the house.
Yeah.
And okay, sorry. Tangent. Okay.
Where were we?
I know this happens every appointment.
Preventing SIDS. Well, see, I run the appointments though, so I make sure I shut that down and I can keep rolling. I don't run this.
Yes.
SIDS.
Bad.
Back to sleep campaign. Yeah, put your babies on their backs, in order to go to sleep. Increased risk if they're up on their sides. Even more increased risk, if they're on their bellies. And then keep the crib or bassinet looking like a jail cell, nothing soft, and fuzzy, and they're just a firm mattress with like a tight sheet or something, over it. Nothing soft that might get, over the child's, the face, and that includes bumpers. That includes rail bumpers.
I know, and they shouldn't even make them anymore. And I know how cute they are, but just
and
stop
there's
it.
a move to not. There is a move to not. Don't co-sleep. From SIDS perspective, there are a lot of positive things that can come from, co-sleeping, but that is a huge risk factor.
So by co-sleeping, I think he means don't sleep in the same bed as your baby, because
correct.
Actually
or
co-sleeping
couch, or chair
or any of that shit. But like co-sleeping, actually you should sleep with your baby in the same room as you. That's great.
Absolutely.
But don't have your baby in your bed.
Yes, thank you for clarifying.
Yeah, sorry.
Yeah. Don't sleep on the same surface that your baby is sleeping, So don't put your baby on your bed, in a bassinet, put the baby on a separate, and on the separate surface. But yeah, at least until 4 months. American Academy of Pediatrics says at least until 6 months, but at least until 4 months. From my advice, in the room, right next to you, right next to you. Things that can, I think I got, overheating. Oh, that's overheating. Don't dress your baby in giant snowsuits and and things in order to go to sleep, and hats. See, that's a newer recommendation because outside of the first couple of days when they're having trouble regulating the temperature, don't put a hat on your baby. If your baby is sleeping hot, they're less likely to wake. They're less likely to wake up.
Yeah.
And also a newer one in the 2022 recommendations is not to elevate the mattress.
Oh, that's a new one.
No, that is a new one. Yeah. Hats in the elevation are a new one. And now there may be reasons, if it's ordered by your healthcare provider to elevate, for reflux, and the like.
Yeah.
It is a standard practice. Don't elevate. It should be a flat surface. Things that can be protective against SIDS: breastfeeding.
Mm-hmm. Yes.
Nurse your baby.
Yes.
You can talk all about that.
Yes.
But breastfeeding can protect against sleeping on the back, on your back, and protect against SIDS. And pacifiers can actually protect. Pacifiers can actually protect against SIDS. That's about all I have to say about SIDS.
All I have to say.
I mean, I could say a lot more about it. I could actually say a lot more about it.
No, I know there's so much to say, and there's so much research, and there's so many debates and stuff. But pacifiers is a really good point, because I know there's a lot of people that are like, oh my gosh, the baby's going to get addicted. And have you heard parents use the word addicted and pacifier together a lot?
Yeah.
Yeah. It's insane. But what's really amazing people don't realize about, and I didn't even realize about pacifiers, is it helps so much too with helping those oral muscles. And an occupational therapist taught me this, but actually if you're struggling with your baby having a strong enough latch, just kind of having that passy and a few times a day, pulling it out slowly. So they have to strengthen that. Pro tip. Pacifiers are great. You can have a very healthy, long breastfeeding relationship with a child that still uses a pacifier. Awesome.
Absolutely. Do you want to sing Metallica?
Metallica.
They have a song about SIDS.
Do they really?
Yeah.
I didn't know.
I'm not going to sing. What else about sleep? So I had to get the SIDS thing in there for talk about sleep.
I think
I could just kind of march up the age.
Should we do that? Let's do that.
So when babies don't have circadian rhythms, they need to wake up every 2 to 3 hours, in order to eat. And that sucks for parents. I think one of the only reasons that our species survives is because mothers and fathers sometimes don't remember how horrible it is to have an infant and wake up every 2 to 3 hours in order to feed them. Because your brain can't remember anything if you don't sleep. If you've been to college and you cram and you're up all night and then you get an A on the test and then a week later you can't remember anything. But I swear humans don't remember how awful it is to have babies, and then 3 years later, 2 years later, they're like, that wasn't so bad. I don't remember that being that bad. And then boom, they have another. Anyway.
Yes, I'm case in point.
So babies need to wake up every 2 to 3 hours to eat because they don't have these natural circadian rhythms, and that can really wreak havoc on parents, on parents' sleep. And that can be a big problem because sleep deprivation can lead to problems with being distracted, and this leads to increased automobile accidents and increased stress, and chronic lack of sleep will cause things like cancer and Alzheimer's. And sleep is incredibly important with all of the hormones and problems with postpartum depression. With postpartum depression, adding a lack of sleep, in there can be profoundly problematic, for parents, and then sometimes even infants. So once your baby starts to move out of that, I need to eat every 2 to 3 hours, go with it, and for this reason, I differ a little bit from the American Academy of Pediatrics about when you move babies out of, the bedroom. Starting at about 4 months, tends to be the best time to avoid what we call infant sleep associations. So you put the baby next to you, not in the bed with you, in a bassinet or a crib in your room. Baby's used to waking up every 2 to 3 hours in order to eat because they need to. And then what happens then when the baby starts waking up every few hours, not because they need to, just because they're restless or they're a little bit too hot or their sleep cycle bored. Just happened, right? Well, every time that infant is ever woken up for its entire life, 4 months of life, but their entire life, they've been fed. So they wake up and they need to be fed. Right? And then this leads to a pattern of sleep deprivation in parents. So before 4 months, you cannot move them out. Like I said, AAP says at least 6 months, but maybe closer to 12 months to get them out of your room. But moving infant out of the room is going to be a fantastic way to teach them how to self-soothe when they truly don't need to eat. Still at 4 months old, they're not going to be sleeping 10 hours a night. They're still going to be waking up, from time to time in order to eat. But then you can teach them, that mom's not always going to be there. Dad's not always going to be there when I wake up.
And that's so valuable. 2 hours of sleep can for a parent, just an hour of sleep is just like a game changer.
Absolutely. Absolutely. And other ways to prevent these sleep associations, right, is don't let your baby fall asleep in your arms and then put them in the crib. What that teaches your baby is that the place that they fall asleep is in your arms, and the place that they wake up is in their crib. So when they wake up, they're in the wake-up space. This is where I wake up.
Yes.
This is where I cry so that I can get put back to sleep because I need to be put to sleep in somebody's, in somebody's arms. Putting them to sleep in the crib, getting them tired in your arms, rocking them, feeding them, singing to them, whatever you do, for your bedtime routine, and then putting them down in the crib or bassinet, tired but yet awake. So they start to fall asleep in this space, and then when they wake up, they're in the space where they fall asleep. And then they'll fall asleep. They'll fall asleep easier. That being said, never wake up a sleeping baby, just like never feed the gremlins after midnight or something. Just don't wake up a sleeping baby to start the whole process over. If they're asleep, they're asleep. But try your best to not do that. Would you say that goes just at night, or would you say that follows through? At what point do you start waking the sleeping baby? At what age? If your baby is newborn, and it's not waking up after 4 hours in order to eat, then you have to wake them up. You have to wake them up to eat.
So my baby, who your patient, my baby, he is 6 months old, and he really likes to party at night. Which I have totally indulged, and it's not good. But I've noticed that like if he takes like an afternoon nap, that like
I see what you're saying.
yeah. So like
Yeah. So if you're trying to once you're around 6 months old and you're starting to get some semblance of a circadian rhythm, some semblance of a sleep cycle. If you have a nap that's too late, too late in the day, then you're not going to go to bed, properly. And so if you need to change their sleep cycle, like day-night confusion, I guess I may have misspoke when I said never wake a sleeping, a sleeping baby. So if you're dealing with a day-night confusion or you're trying to switch a sleep cycle, then yes, you keep them awake. Keep them awake to try to shift, shift their schedule. And a lot of people do this backwards when they try to shift a schedule. They try to put a baby down, or anybody. It could be an adolescent who needs to go to sleep to go to school on Monday, but to try to go to sleep when you're not tired. Put yourself to bed when you're not tired. That never works. Humans cannot fall asleep, on command if we're not tired. We need to build up sleep pressure in our brain as a molecule called leptin goes up. And there's actually lots of other things in there also. But if you're not tired, you won't sleep. So if you want to change a sleep schedule, you need to wake up when you need to. When you need to wake up. It's waking up at the proper time that is the first step to changing anybody's sleep schedule.
Sleep hygiene in general is like an entire whole
absolutely.
5 episodes.
Yeah,
but,
absolutely. So where was I? Moving the baby out of your room, so that they don't start to get these sleep associations and then need you to wake up in order to put them, back down. Another tool that can be useful in helping a child to learn how to fall asleep, on their own, is something called a transitional object, or a lovey. Yes. Right? Everyone knows what a lovey is. It's like a washcloth with a squeaky head, on top, right? Yes. A lovey, or a small stuffed animal, or a blanket, or something like that. And now, for
typically a face though is good, right? As what I've read is that
it's a face. The
lovey has a face, like a bear, or
right.
It's a transitional object.
Yeah, a transitional object, and you don't want anything in the baby's. Officially, you don't want anything in the baby's crib with them until they're 1 year old. For SIDS, for SIDS recommendations. But if your child is demanding that you nurse them or sing to them or hold them, in order to go to sleep, this transitional object can really help. Now, you can't take a toddler and throw a blanket at them and say, use that.
This is your transitional object.
Right. This is your transitional object. You will sleep, child. No, you can't. You will sleep. No, you can't.
Take your transitional object and go to sleep. Yeah.
So you need to develop one.
Yes.
So whatever process that you're using to put your baby to sleep or your toddler to sleep, whether it's, nursing them or singing to them or rocking them or reading them a story, you incorporate this object. And you rub their face with it as you're singing to them, and you do this for a couple of weeks, as you're putting them to sleep, and then they start to associate your comfort, and falling asleep with this, this object, and then the idea is that if the object is then in the bed, with them when they wake up, and they want you and they want to help falling back asleep, then they have this object, and maybe that's enough from time to time, in order to get them to fall back, asleep. Is an extremely useful, extremely useful tool.
Super useful for transitions to daycare too.
Absolutely.
And sleeping at daycare, and a lot of kids sleep differently at daycare than they do at home. And a transitional object is just a really healthy thing to have in child, but make sure you have enough of them, because it really sucks when the transitional object is ruined or disappears.
It does.
So get them hooked on something that you can Amazon overnight yourself over and over again.
So I'm going to tell a story now about transitional object, about my own child. Her name is Julia. She's 20. She's on the St. Paul Fire Department right now, but she used to be small. And during a move across, I don't remember where I was moving, but during a move.
During your important doctor career.
Yeah, during a move, and I had a toddler, or maybe she was 3, she still had this transitional object. And it was, I thought, super important, have this transitional object through this move, right? That's what it's for. It's for transitions. Transitions from being awake to being asleep, or going to daycare, or moving across the country. Well, it got lost because, moving in boxes and... Right, it got
because
lost.
Of course it did, right?
Right. It got lost. And it was really hard for about a week. And then she seemed to get over it. It's like, eventually you're going to outgrow your transitional object, right? So she seemed to get over it. And my wife and I talked, and we're like, well, we found it then. Sorry, we found it. It was under a box or something. What was it? It was a washcloth with a squeaky head on it.
Oh, was it an actual lovey?
It was a lovey. Yeah, it was a lovey.
Okay.
And we actually found the thing, and we talked, like, should we give it back? She seems to have just started to outgrow it. And we landed on, let's give it back, because we just early in the move, and it's still going to be a whole lot of new things, a whole lot of new transitions, so let's give it back. And so I had this really clever, I thought it was clever. In retrospect, it just scared her. But this idea that I'll put it outside on the front step and ring the doorbell, because she always loved to answer the door. She'd hear the doorbell and she would run, and she would just love to answer, because there's somebody there to see us, right? And there's a lot of people who like ring the doorbell. We moved in, and it's like neighbors giving us cookies and things like that. She's like, I want to answer the door and get the cookies from the neighbors. So I put it on the front step, and I ring the doorbell, and sure enough, Julie comes running down the stairs and says, I want to get the door. And then Julie just opens the door and just, pulls the door open and looks around and is confused. There's nobody there. And I was like, well, there's nobody here. And then looks down. She was not happy. So she's, still some magical thinking, but also learning some logic. And she was not happy, and she took a step back and kind of squared off with it almost, and she just stared at it, and then she looked at me and thought she better look back. I'm not going to keep my eye off of this. She thought it was like Chucky or something coming. Yeah,
what did she do then?
Well, then she thought that she needed to get a bit more aggressive. Said letting it sit there might be dangerous. So she grabbed it by the neck and held it at arm's length. And she stared at it in the face, this little squeaky face. And in her childlike speech, she said, what the hell is this? That's exactly what I was doing. And she thought that this doll, this lovey, had come to life, and like we'd left it in the previous home, and it had traveled.
Wow.
And then, after staring at it in a death grip, then she got a big smile on her face. And then she held it, and she said, I know. The old neighbors found it and brought it to me.
Oh my gosh.
Anyway, that's my story about the transitional object.
That's like the most perfect note ever to like end the podcast on.
Yeah, we can. That sounds good. We can talk more sleep later. There's a lot more sleep to talk about.
Thank you so much for coming and being here.
My pleasure.
Awesome. Oh my gosh, he's the cutest.
Dr. Cook?
He's so...
That was really good. You did a great job.
Oh, that
Are you proud of yourself?
I don't know. It feels
You should
weird.
be proud of yourself.
Thank you.
Yeah, you did it. You can do hard things.
I can do hard things.
Should we answer a question?
Yeah, let's do our mommy
mailbag.
Yep. Yeah, and then...
Mommy mailbag.
And then, girl, I'm getting tired. You getting tired?
Yeah, I'm getting tired.
Yeah.
All right, this one is from Dan in Wisconsin.
Of course, Dan is from Wisconsin. Okay.
My 3-year-old is scared of the toilet. She won't stop wearing diapers, and she can't go to preschool till she's potty trained. What do I do?
Ooh. Sophia, this is a way more you question, because you've potty trained a lot more kids than I have.
I potty trained a lot of kids.
And you potty trained my kid.
I did potty train your kid.
So,
mostly.
Girl, you go with it.
You also potty trained your kid a lot. Your kid is scared of the toilet. That's really tricky. I think that the first thing I would do is, and this sounds really weird if you're not a parent, but use the bathroom around your kid. I want to preface this with, as a teacher, I do not use the bathroom around my students. I have never and will never. But I do encourage my students to be in the bathroom together.
And watch their peers.
Watch their peers, which is developmentally appropriate at 2 to 4.
Exactly. And I would just like to say scientifically, like the hormones in the brain, like the brain isn't even developed enough to create all of the hormones that like make a libido arousal because puberty hasn't hit yet. So it's totally
fine
within guidelines.
Yeah. So having them watch other people use the toilet is good. I would also say that you might benefit from having your child put something else in the toilet. For example, a drop of food coloring, right? Have some interaction with the toilet that is playful, where they see the toilet is safe. Have them flush the toilet while it's empty and have that be their only interaction with the toilet in that moment. I guess I'm like basically saying exposure therapy, right?
Yeah. And what I'm saying is your kid's probably scared because it's loud, because that's why most kids are scared of toilets. So my kid still doesn't flush the toilet because she's scared of how loud it is. And so they just cannot. He cannot flush.
Just not
You
flush.
could just tell him, like, I'll flush for you. No big deal.
Yeah. A lot of it comes back to who your kid is and what their exact issue is. You could also try potty training toilets, right?
Yeah.
I would recommend getting a doll with a toy toilet so that you can play act using the toilet with the doll. That can be really helpful. I would also just like narrate your own experience as a parent with feeling pee in your body. The way I say it, the language I use around potty training is, I want you to be your own body boss. Oh, I'm feeling in my body right now. I feel I have some pee. I'm going to be a body boss. I'm going to go use the toilet. And you need to narrate that around your kids so that they start to put together how they're going to connect the feeling to the action. Right?
Yeah. And so I have just 2 little tips to add to that, and then we're going to wrap up. My first one is, if at all possible, do get like a smaller potty. And like sitting on the toilet is a weird experience. Like if you've never felt it before, it feels like your guts might fall out. Like, whoa. And like pooping also, like is that supposed to stay? Like that's supposed to like be in my diaper. Very weird sensations. So my first like bit of advice would be, if you at all possible get a smaller potty, put it in the bathroom. And when you go potty, have them sit on it with you, because they love to model what you're doing.
Yeah.
You say, we're both
and like no
using
pressure.
our potties. Yeah. And I would even like sit on the potty longer than I had to and like would read her some books while we were both sitting on potties.
That's a great idea.
Yeah.
I think step 1 is dealing with the fear before you're even going to get into potty training, really.
The other thing, the big, like, because they say, you know, typically when you go into potty training, you have a big weekend where you just do like no pants and they just like pee wherever. So with that weekend with Eloise, we did put her potty in the living room, and she got to have a lot of movie and TV time that weekend, and she just got used to sitting on, because the rule was the TV could be on if you're sitting on the potty.
Oh, yeah.
Yeah. And so so then she got comfortable with and then she sat on it long enough that she suddenly was peeing, and she's like,
I did it.
Yeah. If a kid doesn't get access to a lot of Disney and then you tell them unlimited Disney if you're sitting on your potty, they will sit on that. And then she did it. And then it was like she had this instant confidence in herself because she had done it the first time. The hard thing was over, and that was it. Yeah. So those are my pieces of advice.
We'll talk about it at length in an episode.
Yes.
Someday in the future.
Yes.
But for the moment, Dan in Wisconsin, I would recommend finding ways to be around the toilet with your daughter where she is feeling no pressure and feeling safe.
Yeah. Yeah.
Yeah.
And even connecting with you, because connecting with you is feeling safe. So if even the toilet, I know it sounds silly, but even if the toilet's in the vicinity, if she's having a safe connective experience with you, that automatically feels safer.
Yeah.
Yeah. So.
But thank you for joining us,
yes,
everybody.
Thank you. Thank you.
Thank you.
Thank you.
Yeah.
All right. You can find us at MindMomBodyRN.com. We offer consultation services. And until next time, take care, Mama.